is a variation in pulse amplitude occurring with alternate beats due to changing systolic pressure. It is best appreciated by applying light pressure on the peripheral arterial pulse and can be confirmed by measuring the blood pressure. When the cuff pressure is slowly released, the phase 1 carotid cough sounds are initially heard only during the alternate strong beats. With further release in the cuff pressure, the softer sounds of the weak beat also appear. The degree of pulsus alternans can be quantitated by measuring the difference in systolic blood pressure alternance between the strong left ventricular failure. In clinical practice, true pulsus alternans is rarely seen in the absence of significant left ventricular myocardial failure and should prompt further investigation to determine the severity and cause of left ventricular myocardial dysfunction. Although pulsus alternans almost exclusively occurs in systolic heart failure, it can occur rarely in diastolic heart failure. It may also be evident in the following situations. Left ventricular pulsus alternans without systemic arterial pulsus alternans has been observed in patients with hypertrophic cardiomyopathy, and a significant rest or provocable outflow gradient. The mechanism remains unclear. Abolition of left ventricular alternans occurs after successful myomectomy. Pulsus alternans is rarely encountered in patients with cardiac tamponade. It can occur in the presence of marked tachypnea when the respiratory rate is 1/2 the heart rate due to an inspiratory decrease in the pulse amplitude. The pulse abnormality disappears when respiration is held transiently. It may be seen in patients with severe aortic regurgitation. It is, however, rare in the absence of left ventricular systolic dysfunction. Pulsus alternans is frequently precipitated by ectopic beats. Apparent pulsus alternans may be observed in patients with a bigeminal rhythm. In patients with bigeminal rhythm, the premature beats are usually out of phase with the normal beats, and post-ectopic pauses are appreciated. Simultaneous auscultation of the sequence of the heart sounds and palpation of the arterial pulse can differentiate between the true pulsus alternans and apparent pulsus alternans due to bigemini. Pulsus alternans should not be diagnosed when the cardiac rhythm is irregular. Pulsus alternans is more common with faster heart rates. Pacing-induced tachycardia can precipitate sustained pulsus alternans in patients with idiopathic, dilated cardiomyopathy and is associated with worse prognosis. Mechanism of pulsus alternans. The precise mechanism for pulsus alternans remains unclear. Alternating preload and incomplete relaxation, although have been proposed as a mechanism of pulsus alternans. Changes in the afterload, which is lower before the strong beat because of the lower output during the weak beat, may also contribute. It also has been suggested that a change in ventricular contractility is the primary mechanism. Changes in the activity of the sarcoplasmic calcium pump with alternate strong and weak beats appears to be the mechanism for changes in contractility. In experimental animals, acute myocardial ischemia is associated with regional pulsus alternans, leading to the hypothesis that alternating potentiation and attenuation or deletion of contraction amounts for the pulse abnormality. Thus, the pulsus alternans may result primarily from an alternating contractile state of the ventricle, the magnitude of the alteration of pressure and stroke volume.